Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. My name is Bushra Noor and my roll number is BP1650057. Today I am going to present the topic is rational use of drug, and the drug is Rifampicin. Now start with the indications of rifampicin. So rifampicin is used for the treatment of tuberculosis, and it's also used for inactive meningitis. But this drug is used along with isoniazid, ethambutol, pyrazine and streptomycin. Along with the TB, it is used for leprosy, for gram-negative, gram-positive Staphylococcus aureus, Staphylococcus pyogenes, verdans, and for gram-negative bacteria, Haemophilus influenza. It is also has some anticlimacterial activity, and nowadays it is used for brucellosis. There are many adverse reactions of this drug, and that include dermatological reactions like rashes, pruritus, urticaria, and flushing. In case of hepatic, asymptomatic elevation of liver enzyme and hepatitis. In case of GI problems, heartburn, epigastric distress, anorexia, nausea, vomiting, pancreatitis, cerebrovascular colitis. In case of hematologic, thrombocytopenia, hemolysis, hemoglobin decrease, and renal failure are the adverse effect of these drugs. Mechanism of action of rifampicin include this drug bind to the DNA-dependent RNA polymerase enzyme. This enzyme is usually responsible for the production of mRNA, RNA, and tRNA. If that is not able to produce, no protein synthesis will take place and no growth and multiplication of bacteria will be proceed. So if the bacteria is not proceed, no TB will be further proceed. And this drug is bacteriostatic, means it only stop the growth of bacteria, but this RNA is not present in the human but not act on the human, so there is no problem with this drug to the human or the animal. Now the interactions of rifampicin. Rifampicin along with anticoagulant like warfarin reduces its effectiveness because rifampicin is a potent hepatic enzyme inducer, so it increases the metabolism of warfarin. Rifampicin along with steroid digoxin and propranolol, that in the bioavailability of these drugs decreases. Phenytoin plus phenytoin, rifampicin plus phenytoin, both of these drugs, if are given along with given in combination or at the same time, then decrease the level of serum in the serum level of phenytoin will be decreases. Toxicity involved in rifampicin is flu-like syndrome, that is the most common with intermittent dosing. Along with this, hepatotoxicity, thrombocytopenia, myasthenic reactions like nausea, vomitings, and others, and rashes. Acute renal failure, this is rare. Now the antidote of rifampicin up till now is not available. If we talk about the dose of the rifampicin, there are different dosage forms are available for children and for adult. For adult, 10 milligram per kg once daily dose is available. For children, 10 to 20 milligram according to the body weight drug is available. Dose adjustment in case of renal impaired patient is not required. The available dosage forms are oral, capsules, and syrup. And in IV infusion, powder forms are available in milligrams. In case of topical, 1% ophthalmic ointment are available. Preference, if we talk about the preference, the preference is oral because it's cheap and readily available. That's why it is most preferable. Now Remactil 2% syrup. This product is manufactured by Sandoz Labs and it is available in the price of 129.70. And this drug is used for tuberculosis and other kinds of infection. Side effect of this drug is heartburn, nausea, menstrual change, headache, and etc. It is contraindicated with patients who are hypersensitive to this drug. Now we are going to start a case study on a TB patient. Here is a patient who is 52 years old. She is female and who is presented to ER department with complaint of cough productive of small amount of yellow sputum with the last month. She has experienced increasing fatigue, occasional shortness of breath, and mild chest discomfort. She is now periodic night sweat, and last night she has a temperature 38.9 degrees centigrade. 2 nights ago she noticed a streak of bright red blood in her sputum without any oral test. The only medication she is taking right now is the OTC drug for cough. 3 months ago, the patient presented to a free clinic and revealed a diagnosis of type 2 diabetes. Now she is type 2 diabetic patient. A purified protein derivative test required to work clearance, and that is positive and she is positive PPD test, but the chest x-ray showed no active disease, so she was cleared to work. Now we are start to make soap notes. Here we have subject. The subject is a female that is 52 years old, and she has a chief complaint that she had a cough for a month. 2 nights ago, she said that I woke up with a sharp pain in my chest and I cough up some blood. If we talk about the history of this patient, she is diagnosed with type 2 diabetes 3 months ago, and she is immunized with BCG, and she is allergic or intolerant to penicillin because she has rash. Now vital signs. The vital signs is BP. Her BP is increased, R and pressure and pulse rate is 82. Increased pulse rate and temperature is normal, but slightly increased. Now physical examination showed the neck and the lymph node. Few small 2 to 3 mm non-tender freely movable lymph node in left anterior cervical and axial area. Her physical examination include chest examination, that is given by a physician by a laboratory, though a few rare are noticed. Rails are rotated at the left apex posteriorly, and other areas of examined was normal. Laboratory tests suggest that skin test result include PPD, that is 16 mm at 48 hours. Chest X-ray suggests bilateral upper lobe infiltrate with well-defined cavating lesions on the upper left apex. Assessment after all laboratory finding, physical examination, the patient is diagnosed with TB, and now it is suggested to treat the patient with initial anti-TB drugs. Now coming toward the plane, the initial therapy start with RIP, that is 4 drug used for TB as initial treatment that persist for 2 to 4 months. That include rifampicin, isoniazid, pyrazinamide, and ethambutol with the following dosage forms. With the following dose. Now these 4 drugs remain for 2 to 4 hours, and after that 2 drug combination should be given, that is isoniazid and rifampicin. Along with these medication for TB drugs, for anti-TB for TB, we also give the anti-diabetic drug, that is for initial treatment is metformin 500 milligrams, and we suggested to perform some more tests, that is sputum test, liver function test, and TB test. Liver function test is used because this rifampicin is responsible to reduce the level of liver enzyme, and the TB blood test is also used for confirmation of these TB problems. As we said, liver function test, so the reason for that liver function test is that Most of the first line drugs are hepatotoxic, so there is a need to perform liver function test. INH, rifampicin, pyrazinamide are hepatotoxic, but because of their effectiveness, they should be used depending on the monitoring of liver function test. In severe liver damage, only one drug can be used. Therapeutic efficacy of the drug in the treatment of TB can be assessed by the help of clinical like symptoms and signs of the TB diminished, lab like sputum and smear culture, and radiology like chest and X-ray. These are the things that is used to diagnose the TB. If the previous situation of the patient is not going good or there is a problem, then we go for second or third line treatment. In this second and third line treatment, we have different combinations or regimens, like we have different capreomycin in the following dosage form: ethiniomide, para-amino salicylic acid, sodium, and cycloserine. For third line anti-TB drug, we have many drugs like rifabutin, macrolides, clarithromycin, linezolid, and thiazide and other medication, but these are not on the WHO list. But for patients who are not treated with first and second line agent, for that we have to go for third line agent. These are the references from which I have taken the different material from different books and from website. Thank you very much. Thank you very much.